Good morning, good afternoon, welcome wherever you are in the world. My name's Nigel Crisp and it's my great pleasure to be chairing this session today. I'm an independent member of the House of Lords here in the United Kingdom, and for a few years I was Chief Executive of the English NHS. But I've actually spent something like the last 15 years working in low-income countries around the world, mainly on human resources. Large time in Africa and a fair bit in Southeast Asia. So it's a real pleasure to come and join you on a seminar on that vitally important set of issues around human resources. Human resources, which is finally being given priority in the way that it needs to be, as people are understanding we need to get our workforce planning and indeed our recruitment and our retention and our looking after and training our workforces much better than they have been in the past. So I'm delighted to welcome you. This is, as people probably know, the final one of 4 seminars hosted by Health Education England and the World Health Organization, which are exploring the importance of systemic workforce planning. And I think that those are the words, aren't they? Systemic workforce planning, being really systematic about making sure we secure the workforce for the future. This is part of the International Year of the Healthcare Worker, and as I say, the new priority that's been given to human resources. All the 3 seminars to date that we've had have been, one has been on thinking about the big picture of what do we mean by systemic workforce planning. The second one was focusing on how the challenge of responding to shocks, the things that you don't know, the things that are going to affect how you have to change course perhaps whilst you're doing the planning. And the third one was about some of the practicalities about demand and supply and a range of perspectives on this topic. This final seminar in this series is actually going to be about the shared work, the collaboration across the entire health and care workforce. I should point out at this point that the organisers tell me they're not looking specifically for sharing and collaboration beyond the health and care workforce into education and housing and all those sort of areas which have such an influence on health. It's more about the sharing and collaboration within the health workforce and teamwork, if you like, and getting that right. And we've got a fantastic panel of 5 people who are going to kick us off by each giving us some of their thoughts on this important issue and telling us a bit about their experiences. And each of them, when they finish, will pose one question to the audience. So you can sit back and listen, but we also want you to do something because we're going to end with 2, if you like, question and answer sessions. The first one will be you answering the questions that have been put by the panelists, and we ask you to do that. Please use the chat section of Zoom to share your views, so your response on the questions. Do that whenever you've got that coming through. And then also please ask your questions in the Q&A session. You'll see both of those at the bottom of the Zoom panel, and I'm sure you're all very familiar with it. Now, this is one of the groups that I'd like to just mention here is that we have an exceptional group of colleagues from 7 countries who've been participating in a series of action learning sets being managed by Health Education and the World Health Organization partners at the University of Salford. And these action learning sets aim to create lasting and strong communities of practice who can learn from each other and support capability and capacity. And following all the events of recent times, that planning capability and capacity is so important. So if you want a theme for today's session, it's really about collaboration, it's really about shared learning. And I certainly hope, and I think the organisers hope, that people will carry on beyond these seminars, working with each other, making links, learning from each other, and carrying forward this vital work. Just one quick reminder to our international colleagues, this seminar is being simultaneously translated into Russian. So if you prefer to listen to us in Russian, please select that as your preferred language. You can do that by pressing the interpretation button at the bottom of your screen, and the recording will be made available to yourself. I should say we're actually recording this, as you will know. The recording will be made available to yourselves in the next few days. So I think those are my introductory remarks, really important issues we're going to discuss today, and a great group of speakers. As I say, we're going to ask you to do some work. We want you to respond to the question or the questions that each speaker asks you, and we want you to put in questions into the Q&A. I should say to the speakers, I'm going to be a bit tough on time. Each of you have got 10 minutes, and by the time the 10 minutes is up, I will start. I may interrupt you. Please don't take that as me being rude. It's just trying to keep the process going. So on that note, it's my great pleasure to introduce our first speaker, who is Professor Francis Osmawa. I mentioned at the beginning that I was Chief Executive of the National Health Service in England. Well, at about the same time, Francis was actually running the Ugandan Health Service. So we have some common experience, and indeed we've worked together. He's a man who has moved from being a clinician, a cardiovascular surgeon, to taking on this bigger policy and really public health role. And he runs an independent think tank in African-based, but based in Kampala, in Uganda, at Chest. And he has been a special advisor to the World Health Organization Director General. So a man of enormous experience. And Francis, it's really a great pleasure to welcome you and to ask you to kick us off with your 10 minutes on this vital topic. Thank you.
Thank you, Nigel, for that introduction. Those nice words. It's been a pleasure actually to work with you all these years. In my 10 minutes, I have 3 messages which I would like to share. The first message is that health is everything. And we live in an era where I can see a paradigm shift pro-health. The second message is that health workforce is very white. Almost everybody is a health worker. And the third and last message is that the communities, the people themselves, are key to us achieving our aspirations of health for all. So regarding the health is everything and the new paradigm in favor of health, here in Africa, in Uganda here, a child dies, and in this funeral, they say God called the child. The woman dies in childbirth, they say, oh, it was her day to die. We have to change this. And it is the people in the funeral who most likely could have stopped the death. And we are also concerned about global inequalities and in-country inequalities. We want to make the world a better place for everyone. And that is the vision of universal health coverage. So we are here to create a climate of opinion which will make this possible. And we have the SDGs, which have been adopted internationally as our beacons, our guides. Next slide, please. So the new paradigm is in those days when I was Director General in the Ministry of Health. We had people who were telling us from World Bank, IMF, some other places, that health is a consumptive sector, a bottomless pit, and that we should wait for our economy to grow before we start agitating to invest in health. This has changed. In 2019, I happened to meet with Professor Sir Paul Collier, who is now at Oxford University, in a meeting in Germany. And he was at the World Bank as the chief economist when I was Director General. He was one of the people who was telling us that health is a bottomless pit. And he said, things have changed, Francis. For the last 40 years, we taught wrong economics. And the point is that economic growth is about the well-being of the people. And if you don't link profit with well-being of people, you've missed the point. And this message has now come through. And it has been emphasized by COVID. It is now very clear that those countries which do not have resilient health systems are not going to succeed with the frequent pandemics that are expected with climate change. So health is at the center of everything. And then we here in Africa have got all of us got the issue of our demographics. Next slide, please. We have a lot of young people. So these are pyramids, population pyramids of Japan and Uganda. Uganda on the right, Japan on the left. And herein are the root causes of some of the challenges that we face with workforce, particularly with migration. The northern countries just do not have enough young people to service the needs of the older people. On the other hand, we in the south have too many young people. Well, maybe not too many if they are changing to demographic dividend. And we find a way of sharing this global pool of health workers, because migration is part of our discussion. Next. So that group appointed by Ban Ki-moon before he stopped being a Secretary General of the UN, he appointed a high-level commission on health, employment, and economic growth. That was the title of their remit. And they have been among those who have reinforced the new paradigm that investing in health is the right thing to do. Investing in health workforce to strengthen the economy, it creates jobs, and the health economy itself on its own, manufacturing drugs, equipment, etc., contributes heavily to economies of countries. And we are very delighted that this is now on board there to help us to defend health. Next. So migration is increasing. Just over the last 20 years or so, migrant doctors and nurses in OECD countries have increased by 60%. Next. And we in the South are losing. That paper published in 2011 in the EMJ calculated the economic losses of Uganda and South Africa and other African countries losing health workers converted into money. And then who is the donor when the northern countries give aid to us, when in fact we are probably the donors. Even our coffee, we sell them as raw materials, and when they come back, and so on and so on. So anyway, in the terms of migration, migration is a given as far as I can see looking into the future. It needs to be better managed through the WHO code on the international recruitment of health personnel. Next. So now back to the workforce, the wider workforce. In every country, we need a spectrum of health workers, starting all the way from the communities, with community health workers, and to the super specialists who will replace your heart if you need another one, something like that. And every health system needs to think broadly. And to do this calls for a lot of work, a lot of planning, intersectoral work, negotiations, which takes into account gender, social justice, and development of society, cohesiveness of society. But without health workers, no country. Without well-managed health workers, no country can expect to have healthy societies. Next. So we need these health workers who have the right competencies, fit for purpose. And these are some of the criteria which I have been advocating for some time. And for us, particularly in Africa, but they are probably universal. They should be prepared to work where their services are most needed. the challenge is urban preference of health workers. There are some parts of the country where nobody wants to live, but there are people there who need their services. So the answer is to grow people from those communities to become the health workers that their communities need. Number two, they should be trained in such a way that they address the needs of their communities. Disease patterns vary from region to region, country to country, community to community. So when you train a health worker, they should be able to deal with the common conditions of the communities there so that they feel wanted, needed, and of course, producing the health outcomes that we are all looking for. And the third one is very, very important indeed. Delivering healthcare with available resources. And very often in some health systems, there's a lot of extravagance, unnecessary extravagance. On the other hand, it is possible with just the 5 senses for someone to be able to make a diagnosis and to be able to provide the treatment that is needed without wasting money on unnecessary investigations and so on and so on. It's a big story. And they should be leaders in their communities, and the communities expect them to be leaders, change agents. If something is not working right, they should be the ones to engage with the community to put it right. They should be prepared to learn all the time, and of course, to be effective communicators so as to be those effective leaders. Next. So for a national health system to create those type of health workers that we have, the dream health workers that we need, it calls for intersectoral dialogue between the ministries of health, education, finance, planning, and also public service. And we recommended at WHO that they should have what they call in every country a structure called CCF, Country Coordination and Facilitation, which brings together regularly all concerned stakeholders to discuss health workforce planning. And for us in Uganda, we had a top position called Commissioner for Human Resources Development. It has not been filled for the last, I think, 15 years for one reason or another. And it is a problem that we are not planning for our health workers as we should be, generating data, tracking health workers, and knowing how many are in training, leaving training, where are they going, what has happened to them, what are their skills like, is their training serving the purposes for which they were trained. And then we have also what is called Health Services Commission with a lot of powers in the Constitution, but they are not exercising their full powers. Very important also is that we need to engage the health workers themselves through their associations so that they also discipline themselves. They also are socially accountable to their communities, knowing what the communities need and responding to them. And of course, this continuous learning, continuous performance improvement is a challenge for every health system in the world. And let's now have our last slide, and which to me is probably by far the most important message, that the people themselves need to be engaged. Can I have the last slide, please? So during COVID, I was appointed here in Uganda as the chair of the Community Engagement Subcommittee of the National Task Force. And for the last 3 years, I have been spending at least every month a day or two with communities somewhere in Uganda. Village COVID task forces were established, meeting regularly, preferably every month. And we have learned from this experience, number one, that organized communities are capable of owning and taking responsibility for their health. and achieving social cohesion between them. This is the message from Alma Ata, that every citizen has a duty and a right to participate in the planning for their own health. Number two is that organized...
I'm going to have to hurry you up a bit, if you don't mind.
Okay, I've actually finished. Engaging communities is important. The people themselves need to own and be responsible for their health outcomes. Then working with their government and their health workers, they can make sure that their needs are met. Without this, we will struggle. And thank you very much for the opportunity to share these ideas with you all. Thank you.
Thank you so much, Francis. What a brilliant opening for us, giving us a really big picture, picking up on the links between the health and the economy, how vital that is, picking up the differences between countries and the migration issues, but then also picking up these very fundamental questions about the range of health workers we need. And also, it seemed to me from some of your last points, there's no single action here. There's a whole range of different actions. There's no magic bullet. This is a lot of hard work by a lot of people to try and get this right. So thank you very much. I see I've interrupted your question to the audience, which I hope people can see, but shall I just read out, which is one of the major contributors to migration of the skilled wider health workforce from south to north is the demographic realities of the aging populations in the north and the high population growth rates in the south. What can be done to address this? So we've got an aging population broadly in the countries of the north, and we've got high population growth in the south. And this is, of course, encouraging migration. How do we need to manage this? What can be done to address this? Fascinating question. I look forward to seeing the answers to that. So, and you've got a little message on the screen now, I think, showing you how to respond. To answer the speaker's questions, please use the chat function. So after that, let me then turn to Justin Ash, who has another fascinating career pathway. He has been, he is the current chief executive of Spire Healthcare, a private healthcare provider here in the UK, and he's led a great deal of change there. I know him actually specifically through the fact that he now chairs THET, and you can see on this screen he's chair of the trustees of THET Charity, which is a fantastic organization that really links partnerships and creates mutual learning between people in all parts of the world, and particularly between the UK and people in low and middle income countries around the world. So Justin, real pleasure to have you with us, and very much look forward to your 10 minutes. Thank you.
Thank you very much for that introduction, Nigel, and also Francis, thank you very much for your important presentation, and some of your question I hope I may address in part in my presentation. So I'm absolutely delighted to have the opportunity to present today. I'm doing so, as Nigel has said, wearing two hats, that of Chief Executive of Spire Healthcare, which is a private hospital group in the UK, and also chair of THET, a global charity that supports partnerships between the UK and institutions in low and middle income countries. And for me personally, these roles unify a passion for easily accessible, high quality healthcare, and also a belief that global learning can help mutual support. Next slide, please. So I thought it would be useful just to set out, many of you may be familiar with this, the context of the global workforce challenge. So across the world, the WHO calculate there's a shortfall of 10 million healthcare workers by 2030, with huge discrepancies in the density of where they're situated globally, particularly in the global south. And even in wealthy countries like the UK, we have an acute shortage of key professionals. So the Health Foundation estimates we're 7% or 100,000 short in nursing in the National Health Service. And the situation, unfortunately, is getting worse. Although there's been a recent increase in the number of people registering to train as professionals, there is at the same time an exodus of professionals because of the stresses of the pandemic, and many have considered careers elsewhere or retired early. And again, that estimate is that by 2030, the shortage in the UK alone will be 150,000 of what is needed. So I think it's quite clear that we all in healthcare need to work together to address this global situation. Next slide, please. So SPIRE and SET are both determined to play their part in this. Now, to give a quick overview of both organisations, SPIRE is the largest independent healthcare provider in the UK by turnover, just over £1 billion, with 15,000 colleagues and 8,000 doctors. And we do what's, I think, wrongly termed routine surgeries, such as orthopaedics, but also much more complex care, cancer, cardiac, etc., and diagnosis. And we have a clear purpose to make a positive difference to people's lives through outstanding personalised care. Meanwhile, the background map on this slide shows the countries in which SET operates, with offices in Ethiopia, Myanmar, Somaliland, Uganda, and Zambia, 31 staff working towards a world where everyone, everywhere has access to quality healthcare, which we aim to achieve through training and educating healthcare workers in low and middle income countries in partnerships with UK organisations and volunteers, which includes partnerships with over 100 NHS trusts. Next slide, please. So we're very committed at SPIRE to maximising the contribution of healthcare workers to achieve greater good in the UK as a whole. So the question was raised about partnership, and during the pandemic, SPIRE was in complete partnership with the NHS. There's always been partnership, but SPIRE was actually devoted to the NHS during the pandemic. This meant healthcare workers coming from the NHS to be situated in SPIRE, and SPIRE healthcare workers being situated in the NHS. And during the peaks of the pandemic, we provided care for over 350,000 patients whose treatment or diagnosis would have been delayed or cancelled, and we're very proud of that. And we still support the NHS. We treated 190,000 patients last year alone in reducing the much advertised waiting lists in the UK. Next slide, please. And you won't be surprised to hear that providing such support to the NHS and having enough skilled professionals to grow requires a comprehensive approach to workforce planning. So we take a 5-year forward view as far as we can, and most of the initiatives I'm about to talk about were launched over 3 years ago. There's a particular focus at SPIRE on skills mix and multidisciplinary teams, and it's almost impossible to recruit SPOT without such a plan. And we have a very simple strategy: find great people, make sure we keep them by being a fulfilling place to work, and develop them to meet their personal goals. Now, we don't have this cracked, of course, but I thought it would be useful to share some of the initiatives relevant to the debate today. Next slide, please. So we recognise that the shortage of healthcare professionals is such that we have to recruit both nationally and internationally. And indeed, we've recruited over 450 diaspora colleagues since 2019, when we launched a workforce plan. And we believe it's one of the largest and most holistic programmes in the sector. We recruit clinical nurses, radiographers, physiotherapists, but we are acutely conscious of the importance of not depleting scarce healthcare resources from countries that need this most. So we challenge ourselves to recruit ethically, and in particular, avoid countries on the WHO red list. We devote a lot of time to supporting them with good financial packages, relocation, swift processing so they can start work, pastoral support, help with finding accommodation. We have an orientation program and a 24/7 support line. And as most of our international recruits are from the Philippines, we have a number of Filipino operators on this line. And also, because of the technology and the practice and the very specialised training, which can be 5 months before they start work, we hope that diaspora colleagues get new expertise, which they can ultimately bring back to their home communities. We also look after how people work today. One of the biggest challenges for the healthcare workforce at the moment is mental health and well-being, which is much talked about. It's a pressure everywhere, And we have mental health first aiders, a Let's Talk network, and even what we call a nightcap club for colleagues who may be feeling lonely. And simply put, without healthcare colleagues, we can't provide care. And another way, next slide, please, that we approach this is a training program. I think it's the next slide, please. So we have 1,000 colleagues participating in 50 learning and development schemes, and 5% of our workforce are apprentices. And our biggest program is a nurse apprenticeship scheme with 200 nurses in training, all of whom can go on, if they choose, to work in the NHS. So I think this sort of partnership and overall contribution to the healthcare workforce is a fundamental responsibility of any healthcare provider. Next slide, please. Now, clearly a UK organisation has resources to devote to workforce development, but how can that translate to a global workforce shortage? So there's a number of ways in which SET is addressing this. We believe the UK's reliance on international recruitment brings an ethical responsibility to help train and educate more people in the countries that are sending staff, particularly low and middle income countries. Global health volunteering by UK-based staff, including those who've been recruited internationally, brings major benefits to low and middle income countries. It also, by the way, reduces stress and increases engagement in those who are volunteering. We know the depletion of low and middle income countries' health workers directly affects sex work. And we've been examining this topic since 2019. We've held a series of symposia bringing together high-profile global leaders to discuss international recruitment. And I'm pleased and grateful that Professor Osmawa and Lord Chris were both very engaged in these discussions, which were looking for win-win opportunities such as circular migration, official development assistance spending in countries the UK recruits from, for instance, Department of Health and Social Care Future International Workforce Programme, blended in-person and virtual approaches, which are proving very effective. So, for instance, Health Education in England Scale Scheme, and I'd like to commend Health Education England colleagues for the work they've done with SET on this. And if we look at diaspora healthcare staff, international recruits, or British-born trained staff with close link to those countries, we find the skills and knowledge they bring is not well recognised. They are, we like to say, the experts in our midst, whose knowledge of other healthcare systems should be celebrated as we bring their innovation into the UK. Next slide, please. So a considered approach to international recruitment combined with the recognition of the global workforce challenge has the potential to turn a source of tension to mutual benefit. Now, obviously, we're far from the reality of this being a virtual circle of support today. But it starts with recognizing the mutual benefit of partnering with low and middle income countries and celebrating the vital role of healthcare diaspora. SET has conducted detailed research on the role they play in UK health provision, and I can do no better than recommending to you SET's sponsored research paper, Experts in Our Midst, which brings to life just such celebration. And I'm very personally committed through both roles to ensuring this mutual benefit and contribution is recognised. And the fact is that the movement of healthcare workers across borders can be...
Justin, I'm going to have to ask you to speed up, if you would, please.
Very good. Source of learning, but it must be managed in ways that recognise that we're in this together. And finally, I've been asked to leave you with a question. And mine is, what initiative could most enhance the appreciation of international diaspora in UK healthcare? Thank you very much for listening.
Thank you very much, Justin. Again, another brilliant presentation, and showing how your two roles fit together so wonderfully, and also demonstrating to us how good practice in public-private partnership can work in reality, and then picking up these interesting points about how you've looked after the diaspora within your organisation, and also about creating nurse apprenticeships. You again come back to the interesting point that Francis made, that there's something here about changing opinion. You know, we need to change this whole discussion, see people from the diaspora here in the UK as experts in our midst, and think much more about circular migration. I see that tunes in with quite a few of the comments that are coming through the chat. So thank you very much indeed for that. So our third speaker is Maureen Mahoney, who's the Director General for People Management in a very different context from the last two, in the Ministry for Health in the island of Malta in the Mediterranean. She actually graduated from Leicester, but for the past 26 years has been working in Malta and heads up the HR function there. And she has been working on drafting a health workforce strategy for the next 8 years. So Maureen, very much looking forward to your 10 minutes. Thank you.
So good morning, and thank you for inviting me to participate in this session today. I am very honored to be here. So as you have already stated, I have been leading a team which has been working on a national health workforce strategy for the next 8 years. We started working on it a couple of years ago with a number of timeouts obviously due to COVID, but here we are, and we will be launching the strategy later on this month. Next slide, please. So there are a number of issues which are tackled by the strategy, mostly related to HR planning. So we plan to change the way we are working at the moment with regards to planning our health workforce. We are currently, as a ministry, bound to provide a 3-year HR plan, which is the system adopted across the public service. So basically, it is the same system adopted within other ministries. But obviously, this is not enough for us, because we need a system which is more evidence-based and longer term, especially given the fact that producing a healthcare professional takes longer than 3 days. So we need 3 years. So we need to plan longer term. We have, in fact, collaborated with WHO in developing a bespoke tool aimed at assisting us to achieve this. And this tool will also be presented during the launch of the strategy. And I would like to thank WHO for this collaboration, because we wouldn't have done it without their support. And obviously, we are very hopeful that once we start using this tool, we will have a clearer picture of what we actually require as health workforce in the future. Next slide, please. So this tool considers a number of trends which to date we had never considered, including the list in the slide: demographic, epidemiological, sociocultural, technological, productivity, task shifting, and political. So these were issues which to date we were not considering when planning our workforce for the future. So again, we are hoping that this will bring us to a more accurate way of planning our workforce for the future. Next slide. So how will we sustain the service in the future? Malta's healthcare system is nearly completely run by government. It is a public healthcare system. There is very little private input into the system. So our population depends on the system provided by government. But there are a number of options which we are looking into with the intention of sustaining the service which we provide to our patients. And this includes, in fact, public-private partnerships, which we already use to a certain extent, especially in the elderly sector. So the government actually takes up beds for public patients into the private elderly homes. We are also looking into task shifting, so especially in those areas where we have a lack of resources, there may be a number of tasks which can be moved from the professional onto other categories of employees, especially related maybe to clerical or administrative duties. These may be shifted from the nurse, for example, onto a clerk or onto a manager. Upskilling of staff, and here we have already started working with our educational institutions in order to provide training to our staff, especially those in supporting grades. Once again, with the intention of shifting some duties from the professionals where we have where we are lacking resources onto maybe those employees who are providing, who are in the supporting grades. And we are also looking at the introduction of apprenticeships. And in fact, we are already working on our first apprenticeship. We are seeing whether we can provide an increased flexibility in certain areas, given, for example, the fact that we have an increased feminized workforce, and in our culture, anything related to family and family-friendly measures are usually taken up by our female employees. So therefore, we may have to look at methods which are more flexible in order to attract or even retain employees. Obviously, digital literacy, telemedicine, robotics, intelligence, artificial intelligence, these are areas which we definitely need to rely on more in the future in order for us to be able to sustain the service that we are offering. Next slide. So obviously, we cannot plan if we do not have visibility of what we actually have and what will actually be available with regards of resources in the future. So the importance of data is very much highlighted in our strategy. And one of the projects we have already started work on is to introduce a new, the HR data system across the ministry, which will give us more visibility centrally at the ministry of our current workforce and any trends which may assist us with planning better. So at the moment, we are relying on systems which are pretty much separate. Everybody has every entity, health entity, every hospital has its own HR data system, and we are working on having a common system across board. We are also discussing very closely the data being kept by the respective professional councils. This is proving to be a bit of a challenge, given that the councils are autonomous and we have no authority over the councils, but we are doing our best to ensure that we have uniformity and accuracy in the data held by these professional councils. It is important for us to know not only those professionals who are currently working with us, but also know whether we have any professionals who are registered and working abroad or are not at the moment practicing in their profession. So this information is important for us in order to be able to plan better. Next slide. Yes, strategic leadership is also a priority for us, and a number of fora have already been set up in order to give health leaders the opportunity to collaborate more, even within the ministry itself. We have instances where entities are working pretty much in silos, so we are getting people together and possibly discussing the possibility of sharing of resources where this is required, and working on uniform systems across the ministry. Obviously, the health workforce strategy forms part of a national health strategy, which is being concluded and should also be launched shortly. So this will nicely fit into the health strategy for the country. My question? So my question is, to what extent do you think that retraining and reskilling are effective measures to counteract shortages of resources in certain healthcare professions? Thank you.
Thank you very much indeed, Maureen. That's a great example of what we're talking about, really, a systematic step-by-step look at workforce planning and playing out through all the sort of issues that you raised for us, including, I noted, one that we haven't talked about yet, really, which is the impact of AI and robotics and technology, and maybe we'll hear more about that later on, but also the importance of human resources data and that last point you make about strategic leadership. So thank you very much indeed for that. Let me then turn to our fourth speaker, who is Professor Laetitia Rispel, who is Professor of Public Health at the University of Witwatersrand in South Africa. And her research focuses on the interfaces between the health workforce and health system performance. And she's published extensively on this. She's also been the president of the World Federation of Public Health Associations. And in that role, she was the first woman from Africa and the third woman in 50 years to be elected. So great to have you with us, Laetitia, and very much look forward to hearing your 10-minute presentation. Thank you.
Thank you. Thank you very much, Lord Crisp. If I could ask you to move to the next slide, please. So what I hope to do in my 10 minutes is perhaps, and the colleagues before me, I want to thank them for making my job a lot easier, but just to reiterate the case for investing in human resources for health or the health workforce, give you a brief background on human resources for health in South Africa, and then share with you our 2030 Human Resources for Health vision and goals, a process which a task team that I chaired on behalf of the Ministry of Health a few years ago. And I want to conclude with lessons for other countries, both on investment in the health workforce, but also trying to pull together some of the threads from the previous seminar series. Next slide. So Professor Osmawa has done a great job in highlighting the work of the High Level Commission. And so safe for me to say that the health workforce is a key driver of inclusive economic growth. It contributes to decent work and job creation, particularly for women and youth in rural and other underserved communities. The health workforce is at the heart of an efficient and well-functioning health system. And I think we've seen that very well during the COVID-19 pandemic. And then, of course, it's critical to the achievement of universal health coverage, which is one of the targets of the Sustainable Development Goals. Next slide. So, and press thank you. So South Africa, for those that might not know, is a constitutional democracy. We have many progressive laws that have been passed since the end of apartheid in 1994. It has a mixed public-private healthcare system, so a very large private for-profit a system that takes up about 50% of the healthcare expenditure, but only provides care to around 17–18% of the population. We have excellent human resources for health, educational and training, and the regulation of health professions is good and has been in existence for many decades. Compared to many other African countries, South Africa has much better national health worker densities. And in fact, the country is not on the critical skills list of the World Health Organization. We pay relatively high salaries in the public health sector, and the process of human resources for health planning is well institutionalized, and it's cyclical. It happens every 5 years. That's not to say that we don't have our challenges, which I want to share with you now. Next slide, please. So the first set of challenges is a disjuncture between human resources for health and health or health system outcomes. And so we have a very quadruple burden of disease, and given the sort of relative stock of human resources for health, we should be doing much better, pointing to issues around performance and productivity. Health workforce planning in the country is hampered by inadequate national capacity and skills, as well as the lack of appropriate and credible planning models. And I hope to communicate with my colleague from Malta to just perhaps get tips on their planning model. There's an absence of national health workforce accounts data for both the public and private health sectors, and that obviously compromises the validity of data on human resource availability and the need. Next point, please. Huge inequities, both between the public and the private health sectors, and it's more acute for the highly specialized skills of medical specialists and dentists, but there are also huge inequities within the public health sector. So the urban provinces are much better resourced compared to the rural provinces. But even within the more rural provinces, you find that most of the health workers are concentrated in the towns and also concentrated in hospitals compared to primary health care. The process that I chaired, we used various models, and all the models suggest both current and projected shortages of skilled health professionals in South Africa. And of course, the COVID-19 pandemic has both underscored the criticality of human resources for health, but has also exposed the chronic underinvestment and vulnerabilities in the health workforce. Next slide, please. So I just want to share with you, and you can press also that I have everything on the slide. So I just want to share with you very briefly the methodology of developing the 2030 human resources for health strategy. So we had a guiding conceptual framework that took into account both the health labor market, but also some of the key legislative and policy aspects. There was widespread consultation and stakeholder engagement, a detailed literature review to collate existing evidence. We looked at an analysis of country level data, and we used 3 models to look at both the current situation as well as projected need. Go on. We also commissioned an extensive health labor market analysis. We had extensive technical support from WHO, and I want to acknowledge Paul Marston, who I see is on the call or on the webinar. We presented to both the health political and technical structures, and particularly we asked them to help us to deal with some of the limitations in the data, some of the dilemmas around particularly mid-level workers, and also some of the contestations which inevitably happen in a process like this. And then lastly, we integrated all of this information into the strategy. And I want to share with you now the vision, the proposed vision, and the goals. Go on. So the vision for 2030 is that, which incidentally both coincides with our national development plan, but as you know, also the sort of target date for the achievement of the SDGs. So our vision is that South Africa invests in the health workforce to ensure quality universal health coverage and a long and healthy life for all people. And the 5 goals that we came up with, Chris. Firstly, we came up with 5 goals. And the first one was that we need to have effective health workforce planning to ensure both that human resources for health are aligned with current and future needs, that we need to institutional, data-driven and research-informed health workforce policy planning, management and investment, produce a competent and caring multidisciplinary health workforce, ensure optimal governance, and then lastly, build and enable productive, motivated and empowered health workforce. Next slide. So the current status is that we submitted the completed strategy in 2020, March 2020, and it was adopted as formal government policy. And in fact, it appears in the annual performance plan of the National Department of Health. However, implementation remains unfinished business, and it's driven by a vicious cycle of the COVID-19 pandemic, which put a spanner in the work, quite significant health leadership turnover, lack of or weak technical capacity, and of course also a reduction of public health sector budgets, which was the exact opposite of what we had proposed in the strategy. Next slide. So what are the lessons for other countries? So the first,
I'm going to have to ask you to hurry up a bit, please. Thank you.
Yeah, sure. So the first lesson is the importance of investment in the health, in human resources for health. Go on. And that encompasses three elements: whole system design, new professions and pathways, and then ensuring that health is everybody's business. So the first aspect, go on, is around what is required with whole system design. It requires distributed leadership, equity, positive practice environments, and of course, a critical aspect of implementation. The second aspect is when you come up with the training of new health professions. In the case of South Africa, we commenced the training of clinical associates in 2009. However, policy uncertainty remains. There's a lack of public sector posts for clinical associates. Interprofessional collaboration and relationships are tenuous, and there have also been unintended consequences that a large number have moved to the private for-profit sector rather than remained in the public health sector. And the last aspect is around health is everybody's business, which includes both the need for research evidence, civil society advocacy, and ongoing monitoring and evaluation. And my very last slide, Lord Crisp, is the question to the audience, which is how do we ensure that the training of new cadres of health providers, such as physician assistants or clinical associates, is aligned to current and future health needs? And secondly, how do we ensure that the contribution of these new cadres is maximized in any health system? Thank you.
Thank you very much indeed, Laetitia. And do everybody call me Nigel, please? I'm using first names here. I thought that was, again, extremely good follow-on from Maureen's presentation, taking us into some of the background issues which you as a researcher have pulled out about the things that the disjunction between the human resources work and system outcomes, and the things that need to be done behind the scenes, and which it can be very difficult to get governments to invest in, such as good data, national capacity and credible planning, when the option is to when people are struggling to invest in employing frontline staff. And this is one of the issues that I think we face. But you also pick up these very interesting points in your question of how do you ensure that you can bring in new cadres of healthcare providers as appropriate and align them with the current and future health needs, and making sure they're maximised and not rejected by the system. So really helpful indeed, Laetitia. And then we turn to our fifth and final speaker, who is Professor Beverly Harden, a physiotherapist, working as the Deputy Chief Allied Health Professions Officer for England, and leading a multi-professional programme on advanced and consultant practice. And she's an honorary professor at Winchester and a board trustee for Carers UK, bringing in another aspect we haven't particularly talked about, I suspect. So welcome, Beverly, and I look forward very much to hearing your final 10 minutes. Thank you.
Lovely. Thank you, Nigel, very much indeed. Thank you for the invitation. Delighted to be here. And I think the key underpinning to liberating the entire workforce to the benefit of population health is really summarised in the quirk of the title of today's session, or the subtitle, which is maximising the contribution of support and other workforces. I would put it to you that we are all the workforce for the NHS, not the support, not the other workforce, but all of the workforce. And I think what that beautifully illustrates is the cultural and the professional underpinning of the challenge for us in liberating all of our qualified, registered workforce to the benefit of population health. And many colleagues have touched on the challenge and the opportunity of upskilling people, of being able to really think differently about how we utilise our workforce. But we have one or two Achilles heels to that we have got to pay attention to. And the more work that we do globally together, the more we collaborate, the more we help the systems to really start to understand the benefit of liberating every aspect of our workforce. Next slide, please. So in the UK, we face a number of really quite significant workforce challenges. Colleagues have touched on them, but we've got big areas of workforce shortfall, not just in medicine and dentistry, but across lots of different professions. But when you start to look at what the professions can do, yes, we all have our unique selling point, but we also have huge areas of shared skill, shared opportunity. Our Venn diagrams overlap in so many areas that we need to get clever at how we absolutely liberate the shared and the unique aspects of our whole workforce. We struggle to retain. We are clever people, yet we do not give people the self-actualizing jobs. It means that they can use their full trained capability, but also advance their skills to the benefit of their population, which would keep them really interested and really engaged in the work that they do. We need to think about the professions. We need to evolve the professions. By definition, we are not static things as professions, yet we all interrelate to each other and we all need to move as one together as we work to redefine scope of practice and develop what we can do. So there's a huge challenge for us, I think, in our global stewardship of professions. We have huge difference across the countries, yet we also have a lot of similarity. How do we really start to think about the opportunity of evolving scope of practice in a truly meaningful way? That allows us then to utilise the full trained capability of our workforce. And I would put it to you that we are not doing that yet. We think we have turned over every workforce stone. We haven't. We are yet to fully understand the full capability of each part of our workforce. And what we do, be it advancing the roles of people, be it upskilling, it has got to be scalable and trusted. Employers need to understand, what can you do? How can I use you? How do I make one of you for the future? And then how would I safely deploy you? And is that okay? People are often nervous of the unknown, or because they don't understand, they go and create a new shiny part of the workforce, which we struggle to then land in the workforce because we haven't yet looked at what we've got already and how we might utilise the workforce we have. So there's a real warning for us about looking and utilising what we have. We also have the challenge of professional competition. We need to see the workforce as one huge set of skills wrapped around a population, and we utilise the workforce talents and skills we have got. It's less about, I need 3 doctors, 2 nurses, a physiotherapist and a speech and language therapist. It's about, what do I need to do to meet the health needs of this population? And of our workforce, who can do that? It adds a level of interest, complexity and challenge, but it liberates a whole new labour market, and it liberates the hearts and the minds of your workforce who want to give of themselves to the work that we need to do. And of course, as with colleagues, we have exponential service demand, huge challenges, but we need to build senior decision-making skills, diagnostic first points of contact that mean that we de-escalate care as early as possible in somebody's pathway, not escalate it. Next slide, please. But everything we do, we have to do together. We have to do, and we have colleagues in the chat have talked about the need to join up all of these enablers. Absolutely. We have got to train people. We have to recognise their skill. We have to pay them properly. We have to supervise them properly so they become confident, capable professionals. And we have to offer career pathways that continue to retain people. And that requires all of us to work together, to create modern teams wrapped around populations. And yes, we need more people, more staff, but we also need different. More of the same is not the solution. That does not mean shiny things. It means using, deploying, thinking about what we have as our assets and really utilising and liberating them to be able to use their full capability to the workforce. Next slide, please. So question 1, do we understand what we actually have in our workforce. And I would suggest to you that we are learning, we have work to do. And I think there's a difference between what you can see today and what you can have in the future with your existing workforce when you run a nationally driven, policy-facing, service-informed progression of your workforce. And that comes down to what can our workforce do? What is their scope of practice? How can I develop nationally with regulators, with government, develop the scope of practice of our professions to truly start to move the full opportunity of the different professions? This is not about substitution. This is not a physio substituting for a doctor or a nurse substituting for a pharmacist. This is about saying, what skills do we have and how can we utilize those skills and reimagine, reinvent what the team is doing because we finally understand the true skills of the people we have in our team. Every profession has a unique scope of practice. Our support workforce have unique scopes of practice. We need to develop and educate people to step up those scopes of practice, as we say, but in the context of a national, multi-professional piece of reform. And the work we're doing in England is across all of the professional groups. That means we can liberate the skills at scale and really enable people to develop that decision-making capacity. But that requires a cultural shift that means the doctors will agree, allow, trust, and devolve that level of responsibility in their teams. I pick my language carefully because it's a tricky thing to work through, very emotive, but it also means the population also have to understand that they may, where they used to see a doctor, no longer see a doctor. They may see a nurse, they may see a pharmacist, they might see a paramedic, and that is okay, and that they're trained well enough, and that is safe. So some real cultural underpinnings for both professions and for society. Next slide, please. An example in primary care, we have got numerous different roles now working within our general practice primary care settings, where 2 years ago I would have gone and definitely seen a doctor. Now I'll go and I could see any one of a number of different professions depending upon why I'm presenting. I might see a dietitian for my colitis, I might see a physiotherapist for my back pain, I might see a podiatrist for my diabetic foot, but I'd be getting expert care at the front of the pathway who is trained and qualified to decision make, de-escalate care if appropriate, or escalate care as appropriate, or treat and maintain in primary care that individual, but keeping people at work, in home, at school, undertaking their informal care, engaged in society, ideally not on a hospital waiting list, not in an ambulance outside a hospital, and not in a hospital bed. Next slide, please. Question 2. I'm sorry, I had 2 questions, but it's an exciting topic. Do we have a clear vision for how we will evolve the professions together, not in isolation? There's no point creating super duper pharmacists if we haven't allowed the other professions to move in tandem so we understand how the workforce evolves. Do we have a national policy position on how we advance the skills of our workforce built into your policy, built into your aspiration for change in service? And do we, as part of that, understand the implications of that on the legal, cultural or lived jurisdiction of those professions, the changes that could have in service and the opportunity to liberate different ways of delivering services, changing the cognitive load. If a GP is no longer seeing sprained ankles and easy patients, to use a phrase, they're going to need to work differently because they're going to be having a higher cognitive load of what they're doing. How do we ensure that the service changes to give them more time with the more complex patients? We've got to make sure there's nationally recognisable education and training. Supervision is key. Supervision is the biggest crunch point for all of us, I would suggest, in the 21st century in stepping up roles, upskilling people, transforming services, so that we can deliver at scale, so the world begins to acknowledge, recognise and move this to become the way that we do our care. That impacts, without doubt, on retention, keeping people in work, but also building decision-making skills at the front end of pathways. Next slide, please. As an example, in radiography, we've got huge challenges around our diagnostic weights. We are working across the professions and across the levels of practice. By upskilling our support workers to move towards taking some of the films and managing care in different ways, we can step up our student radiographers. We can then step up the first graduate level radiographers. We then look at enhanced level practice, where we can then bring reporting that used to be an advanced skill into the enhanced level of practice. We can then step up advanced and consultant practice, which means we then work in a different way with our integrated radiology teams to make sure that we're then able for the radiologists to do what it is that only a radiologist can do incorporating digital and AI as part of those workforce solutions. So hugely important that we move all the professions together to ensure that we deliver. Next slide, please. So across the advancing practice, across all of the professions working alongside medicine and dentistry, we are looking to put in place nationally recognisable stepping stones for people to advance their practice beyond their trained scope of practice, beyond their trained capability. Done in partnership with medicine and dentistry, but done as a way to liberate the opportunity for those professions, to train them to be skilled in the decision making, not substitution, not task shifting. It is developing the clinical reasoning skills, supervising in practice to ensure that people are technically competent. They can also do the decision making required to undertake the task. And it's not a task, it is the critical, complex management of multi-morbidity that we need to have in our workforce at the front end of pathways. Hugely important. But as we've said earlier, it is about wrapping around the advancement of practice, the HR requirements, the pay, the supervision, everything that we need to hold that profession, those professions safe, so that we understand and value their USP, and we understand and value the shared skills that they have. Because the nurse does not want to be forced into the shape of another profession. She wants to be a proud nurse delivering nursing. We've got to understand the professional identity issues for the professions, whilst we're solving the more complex workforce challenges that we have. But this is about reimagining and redefining team and enabling the professions to give of their best. Next slide, please. So, delighted
to hurry you up a bit here, please.
We're finished, Nigel.
I thought you might. Thank you.
Keen that we can continue to collaborate, Nigel, because there is so much learning here, and there's no advantage of one country going off fast in one direction without the rest of the world having a clue where we're going, because we need to really be able to work in partnership to be able to understand, and clearly we're all at different places and different points, but there does need to be visibility of these agendas so we can optimise the opportunity for the workforce globally. Thank you, Nigel.
Thank you very much indeed. I mean, what a terrific presentation to finish off a series of 5 terrific presentations, and quite a challenging one as well. In terms of liberating the workforce, you started off and pointing out the problem with the title, that they're not the other workforce, we're all the workforce. You also asked this very interesting question: do we understand what others in the workforce can do? And that it's not about task shifting, if you like, but allowing people sometimes to work to the top of their license in really important ways. And the importance of thinking about how the professions will evolve, that we're not dealing with a fixed set of issues here. They are changing as people change and as society changes, and as we are seeing a cultural shift. And what I think people like you, Beverly, and people in these leadership roles need to be doing is trying to steer that cultural shift. So we've got a great range of issues there, and a lot of people have raised some really good questions. So I'm going to ask the speakers to respond to some of that. I'm just going to try and make sure I can find out that I can see my panel and see everyone who's here. Good, I can. And if people will put up hands when they want to speak. But why don't I've got about 4 themes here that we ought to work, 5 themes, of course, because we have 5 questions that we ought to work through. And I think let's go back to the first one on migration, not spend too much time on it. But Francis raised it and others have mentioned it, in particular, just in responding to some of the points there. And we saw a number of comments in the comment, haven't we, from people like, I think David Rowlands was making the point, which I have to say I have argued with government for the last 20 years, that if we have 500 people from a particular country, we should be funding an element, at least, of education of professionals in that country. But let me ask 1 or 2 others about their thoughts on that. I won't go to you first, Francis. You've seen some of the comments that are there. Where do you stand on this? Let me go to Laetitia first, given that you're in South Africa, which is both a receiver of migrants and an exporter of the population. Laetitia, do you have a view on that?
You caught me off guard, Nigel. Just repeat the question. The one, is that the one that Justin posed?
It's the one that Francis Osmawa posed about migration, and which a lot of people responded to about how do we manage migration better,
Yes.
so that we're not,
yeah.
we don't have the brain drain, we have something much more circular. Do you
Yeah.
have a view on that?
The reality, Nigel, I always say in the first instance, you'll never be able, there's often a tension between the human rights of the individual and of course the needs of a specific country. But I think in the first instance, we should ask ourselves the question about how do we actually make sure that the pull factors and a supportive, particularly a positive practice environment is in place for health professionals. I think that'll go if we begin to address some of those issues and good management and leadership. That'll go quite a long way to stemming the tide of of migration. I don't have time, but I could kind of go on for a long time on what are the push factors. And I think if we deal with those push factors, then half of the battle will be won. Yeah. That's my view.
Thank you very much for that. I'm gonna turn to Beverly next, if I may, and then Maureen, and then come back to Justin and Francis, who spoke about this already in migration. But Beverly, there's a sort of inevitability about migration, not least from the population figures that Francis showed us, of a huge demand of an elder population in broadly the northern countries of the world, and a huge young population in broadly the southern countries of the world. And Justin also talked to us about making the diaspora feel welcome and supported and part of, and also the notion of circular migration. How are you seeing that from sort of the centre of the NHS, really, or the centre of the Department of Health?
So the key for us is, if we have got colleagues coming to work with some of the countries, we have got to, picking on Justin's point, we have got to develop, nurture, love, bring into the country and absolutely value the talent that we are bringing into the country. And I think the real issue for us, Nigel, is about how do we make this a really reciprocal piece. So if I just pick on an area of work that we're doing around podiatry, we have very, very few podiatrists in England and a huge need. Countries like India have a huge need for podiatrists, increasing diabetic challenge, increasing multimorbidity. But actually, we can solve the problem together, not in a way that drains talent from India, but in a way that creates internationally focused training in a British context, potentially, Nigel. That means we can then also enable India to build its own podiatry workforce that does not exist at the moment yet, and enables part of that challenge, the cultural change, etc., that enables us to benefit the home country as well as ourselves, Nigel, by bringing in workforce who some will stay with us, some will go home, and drive the transformation of workforce back home. So there's a really exciting edge to this if we get it right. That isn't just about hoovering up other countries' workforce, Nigel. So yeah. I think we've got to really try and stay in the space of real, genuine mutual benefit. Yeah.
Can I ask, why isn't this happening? I mean, people like me have been advocating this, and Francis, and we set up a code at the WHO, however long ago it was, Francis, on the international migration, the management of international migration, but it's just not happening, and the UK is not doing well on meeting its obligations. It's happening in some instances with the work that people like Justin are doing in their organisation, but why is it not happening more generally, do you think?
For my opinion, it's a challenging piece of work, Nigel. I mean, the work that our global team have done in HE has driven some really fantastically mutually beneficial pieces of work, but it requires real painstaking attention and fantastic relationships and the real understanding of mutual benefit, Nigel. And I think that's where the time needs to be taken, but in the context of a workforce demand which is exponential and the need to move at pace to recruit. So there's such tensions, I think, Nigel, across the system, that actually sometimes one will win through over the other. The challenge for all of us is how we focus on mutual benefit.
Yeah, I see Carol Kazera is saying we should have an economy of reciprocity, which sounds like a good theme, but how do we get it into practice? Maureen, is this an issue for you in Malta? I imagine as a small island, you either export a lot of people or import a lot of people.
No, actually, it is not such a great issue in Malta being so small, but we do we are slowly depending on an increased foreign workforce. So we are not producing enough health professionals. So in certain areas, we are depending on foreigners too. In fact, we have calculated that about 9% of our workforce is made up of foreign employees. We have actually just concluded a study in order to identify better means of integrating our foreign employees into our system. So whilst not facing the issues possibly being faced by the bigger countries, I mean, you can't compare to Dr. Francis's issues, but yes, we are facing an increased foreign workforce, which we obviously have to adapt to.
Yeah, thank you. Can I then turn to Justin and Francis, and you both already spoke about this. So I wonder if you could say very briefly what your advice would be to countries that, as part of their workforce planning, need to be thinking about migrants coming into their system, or indeed migrants going out of their system. What would be the sort of advice you'd be giving to those countries as part of their systematic workforce planning? Can I turn to you first, Justin, and give Francis slightly longer to think about it?
So, I mean, first of all, workforce planning is key because you need to know where your gaps are going to be in 5 and 10 years' time. If you have a spot response to a shortfall, you will get the worst of all outcomes, which is you'll end up recruiting from countries you really shouldn't be recruiting from.
Yep.
And you'll be recruiting the wrong skills mix, and you end up with exactly what we're trying to avoid. So workforce planning is key, number one. Secondly, of course, is home training, so apprenticeship programs. I mean, interestingly, of those 200 nurse apprentices at Spire, nearly all of them came from the restaurant sector. So there is a whole thing here where apprentices can bring people into the healthcare workforce in a way that you wouldn't do if you follow the traditional routes. And I think that is absolutely key. And then I think the third thing is be really mindful of this being high profile, that you're having to do it and that you really value the contribution. And that as a consequence of doing it, there's an underlying problem to solve, and reciprocity is essential. I think if you do it sort of undercover, you have all the issues we're talking about. If you make it really clear what you're doing, it will prompt internal development and be appreciation for the benefit that has been brought by those colleagues who are coming from overseas. So I think transparency, planning, and appreciation, and having that up front, not subsequent to having done it. I mean, it's a big topic, but those are the thoughts that come to mind.
Yeah, Justin, I've just noticed that there's a question from David Rowlands on this, aimed at you, actually. Can I ask, Justin, how long is international workforce stay with Spire, and how many return to their home country?
So we've only had the programme for 3 years. So far, I don't know if this is good or bad, but none have returned to their home country because they really like working here. And in particular, they do get a lot of training. So they have an ongoing professional development programme. Now, I imagine that we will start seeing that cohort return home upskilled, but we have sort of prided ourselves on making it a place to work, but they don't want to return in a hurry, and most are now extending their visas. So that's the answer. You could debate the pros and cons of that.
Yeah, but that's the straight facts. Thank you for that, Justin. Yeah. Francis, let me come back to you. You raised this issue, and I also noticed there's a question here from Irina Lucheska saying there's no single solution, and she's saying why the idea of reparations paid to the country which educated the healthcare worker has never been enacted. Now, I know part of the difficulty is that people move quite a lot, but do you want to have a final word on this, as this was your question, Francis?
Yes, thank you. It's been a fantastic conversation. And of course, Nigel, you know, we've been at this for a long time. The WHO quote on the international recruitment of health personnel is a beautiful document. And we took almost like 10 years negotiating it. And Laetitia, your minister then, the late Shabalala, was very instrumental in making the noise, which helped the global community instead of competing to share. And the message of the code is that let's produce one global pool of health workers, which we share through the code. The code provides for receiving countries, for sending countries, for the individual health workers themselves. And it was envisioned so that first, every country attempts to be self-sufficient, but if they can't, support the countries who are sending, the countries with those large young populations. And immediately after the first forum, Global Forum on Human Resources, and the adoption of this code, it worked. The US started what they called MEPI and NEPI. They put $130 million into expanding training in our countries for doctors and a similar amount for nurses. The Japanese government did the same in Francophone West Africa, the Norwegians, and so on. But that has switched off, and nobody is talking about the code. If we get out one thing of the others that we want to get out from today, can we agree to put some resources on advocacy for the code? That would be what I would say. Yes, all those things, push factors, pull factors, they are all there and they are part of it. But the code, the migration of health workers is inevitable. It's a given. Let's manage it through the code.
Yeah, thank you for that. I'm actually going to give the last word to Dame Ruth May, who is the Chief Nursing Officer for England, who's written in the chat. We do in England follow the WH code, and we will continue to ensure ethical recruitment. So thank you very much for joining us, Ruth, and for putting that there. Let's switch to another topic. And one of the other topics that was raised was by Beverly right at the end, actually, which was, do we understand what others in the workforce can do? And you were making some really radical comments about the need for the professions to evolve. And it links with some of the other points, the points that Maureen raised as well about, though she used very different language and rather different approach, talking about task shifting, which I'm not sure you see it as task shifting, Beverly. That sort of set of issues of retraining, of professions evolving, and so on. There are some comments again in the chat around this. Can I start by going, perhaps I'm going to go to you again first, Laetitia. How do you see this sort of area of the professions needing to evolve and training to be done in different ways?
So Nigel, I think it sounds very good in theory, but I had a whole lot of questions to Beverly. One of it, which is really the not so much the kind of principle of getting everybody to contribute and maximizing the skills, but you talked, Beverly, about the issue of identity. But I wanted to ask you about the issue of professional resistance. You know, how do you deal with that? The second one is also around this ultimately, if it's a salaried employee, how do you decide then what should be the scales of pay of these individuals? You know, in South Africa, it often, when there's a new task, whether it's nurse initiative, you know, ARTs to expand access to antiretrovirals, nurses are often the ones on whom you know, many of these tasks are kind of shifted. Yet, you know, it's not always commensurate with the benefits that they get. And, you know, and that creates quite a lot of you know, certainly of unhappiness. So I guess I'm not really answering the question, Nigel, but I think it's critical to kind of say in practice, how do you deal with questions of the regulators? the professional resistance that you often face, you know, the kind of like equal pay. In theory, if you then have that a nurse and a physio and a doctor do the same work, then, you know, in the team, then there should be equal pay for equal work, you know, that's performed. How do you deal with some of those practical, you know, issues?
Let's get Beverly to respond to that and get some discussion going on the panel here.
Brilliant, thank you. So, professional resistance. So the work we are doing at the moment in advancing practice across the professions is challenging to every single professional group. So the key way we've dealt with professional resistance, first is we're not using the word substitution because that offends everybody.
Yeah.
We're not, because it's not substitution. I am a physiotherapist. I'm not a nurse. I'm not a doctor. If I want to be one of those things, I need to go and train to be one of those professions. I have a very, very clear scope of regulated practice. So that helps immediately because it takes away, first of all, the threat that I'm trying to be you, because particularly for our medical colleagues who spent 5 years training and have extensive postgraduate time training, they are hugely challenged by the thought that we would substitute into their space. We have a different role and a different purpose. And we work as part of an integrated multi-professional team always. And we have not changed that concept. There's always a multi-professional team that we work within. The other part of professional resistance is that we are working with all of the professions respectfully. I am of one profession. I do not know the detail of nurse training or occupational therapy training or medical surgical training. Where I am working with another profession, or when the team is working, we work with that profession to understand, respectfully working with their professional leads, really seeking first to understand and work with. And most resistance and challenge we come across, that is not just the initial protectionism or anxiety, or comes down to potentially other economic reasons, is the fact that people are scared that we have not understood the nature of their work. And that's why we don't use the word task shifting, because it is not about the task that I do, it's the level of clinical diagnostic reasoning I have to have that underpins the activities that I'm doing to meet the person's requirements who I'm working with. And the issue for us is that prescribing something or doing something, doesn't matter what it is, it's the level of diagnostic reasoning and level of practice that I'm exhibiting, which, picking up on your other point, then triggers my pay. Rather than saying, if I inject an eyeball as part of my orthoptic or my ophthalmic nursing work, if I'm not having to exhibit any further advancement in my clinical reasoning, my responsibility, then actually it remains part of my job role at the level that I am operating. If it does require a different level of practice as part of the main aspect of my role, that needs to be considered. And we have a helpful pay scale in England, which is about equal pay for equal worth based on Agenda for Change, which is a challenging thing to enact at times, but it does give us that underpinning, which enables us to enable the professions to be respected relative to one another, because this is not a professional competition. This is all of us bringing our best to our population. So anything that creates competition detracts from that for us.
Thank you very much indeed, Beverly. And there are some great, the truth about this from my perspective is some great examples where change has been brought about, such as in 2003, when I happened to be chief executive of the NHS, when we introduced prescribing for nurses and other senior professionals, massively challenged. Most doctors opposed it, a few didn't. Today, it's completely non-controversial. I'm sure Ruth May would agree, who's still with us, I see, would agree with that, and has been a huge asset. And that was a massive change. And that was done very carefully in some of the ways that you talked about, and it wasn't about substitution and so on. But I think we've all also seen some awful examples, haven't we, of people being, and I understand a lot of the African experience, which I think Laetitia was pointing to, of what happens is it gets dumped on nurses, because nurses are the people who are always there. And that's the great danger of what happens within that. Maureen, this was your question. Do you want to come back on some of that, and then bring in Justin and Francis if they've got comments they want to make?
What I wanted to add was that here in Malta, we have a very, very highly unionized workforce. So many times when we are considering or looking into task shifting or new roles to be added or new roles to be moved out of, we end up discussing such issues with the unions, because unfortunately, they are pretty militant, especially the union, which covers the nursing profession, which is the largest cohort of employees. So we need to be very careful that we have the unions on board when discussing such issues. It is pretty much a challenge.
Yeah, no, great. Justin, I'm sure you have some thoughts on this from
Yeah.
your experience in Inspire and elsewhere.
Yes, thank you. So first of all, generally, if I focus on the nursing workforce, they have been, I think, an underappreciated group in terms of what they can contribute. Although obviously, in order to do that, there's an upskilling involved, and there's enormous enthusiasm amongst that cohort to develop those skills. And that there was a point earlier made, by the way, the reason that some leave the professions, they don't get to develop. So this comes right back to how do you keep people in nursing? So that's point number one. We're doing quite a lot of advanced practitioners. And actually what we find, first of all, is start with a coalition of the willing. So find consultants who are very up for this to work with in the first case. Don't try and do the hard cases first. Start with those who really appreciate the benefit. Actually, it then comes down to proper planning. So as you upskill your nursing workforce, Laetitia made a good point, make sure you've got your pay scales right so they feel appreciated for the upskilling. But also, you've got to change your systems. You go to see a nurse practitioner first rather than a consultant, which means you've got to change your electronic pre-assessment system. You've got to make sure that when it comes to ward rounds, it's noted that they need to be there at a certain time rather than previously a consultant. So a lot of this, I think, is about careful planning of the healthcare pathway to enable them to be successful. If you don't do that hard work, you end up with somebody upskilled and not doing their job to the fullest of their potential. So we find the really hard work is that pathway planning and actually changing the systems to enable success. And when you then do that, the people who seem the happiest, by the way, are the patients, because they've got the right person with the right skill set and the right communication. So lots of potential, but requires good groundwork to make it succeed, is our experience.
Yeah, thank you for that, Justin. Francis, would you like to just make a final comment on this before we move on to another topic?
Yeah, well, it is a very, very important topic. I wrote a piece about this. I'll share it with you after the meeting. Basically, the ideal is that the various health professionals are mutually supportive of each other. They are like a jigsaw, nurses here, physiotherapists there, pharmacists there, producing the health service for the population. Now, the problems come when there is competition, and sometimes it's individualistic. Who is in charge? Who is the boss? Who is the leader of the other? And then the tensions develop, and then ends up what Nigel, in that commission in which you were, you described it as tribalism of the professions. But we here in Africa really haven't had, Laetitia, I don't know about South Africa, but but this northern part of Africa from you, we have very liberally used, task shifting is not the correct word, but when we have had like shortage of doctors, we have trained clinical officers, which you now call clinical associates. They are new to you, but we've always had them since the first doctor came here, Sir Albert Cook, more than 100 years ago. We had those people who were supporting not just doctors, but also nurses, enrolled nurses and all types of nurses. And these people were allowed to prescribe because they were the ones who were there. So we've grown up with this as a normal. And for going into the future, I think each country will have to decide for themselves. But groups like WHO, who set the norms, need to emphasize that health professionals are mutually supportive of each other. Roles should be clearly defined. skills and their development should be clearly defined. And then we move on from there. Task shifting, WHO has guidelines on task shifting. I was in Geneva at that time at the Global Workforce Alliance. I resisted using that word, but then I failed to stop those who were driving it. Basically, PEPFAR wanted to give money for ARVs, which were to be prescribed by non-doctors, and they said, let WHO issue guidelines and PEPFAR will release the money. And that's how we now have that task shifting getting into professional language. But it's something which is about mutually supportive health professionals.
Yeah, no, I agree with you, Francis, and I would much prefer us to use task sharing. There's a great
Yes.
post, if you can see in the chat or the Q&A, from Juliet Sturgis. In my experience, we have overcome resistance by talking about the skills a role requires rather than the profession it needs to be. And we should define the workforce in those ways, I suspect. So I think that's great. We've got about another 18 minutes or something, so people do put questions in. I'm trying to make sure that I feed them into our panel, and you can see I've mixed the two. Linked in some of the questions in the Q&A with some of the ones in the chat. One of the other questions that kept coming up was about data and about the use of data. 2 or 3 of our panelists really emphasized the point that you can't make sensible decisions unless you've got some sensible data within that. And there was someone asking as well about how do you get government buy-in for some of the changes that are needed, not just the changes needed in clinical practice like nurse prescribing or something, as I mentioned, but actually that you do need to invest in data and governance. Francis, you pulled out these sort of points, and so did Laetitia very strongly in her talk as well. How do we get government buy-in or funder buy-in to investing in some of these hidden things behind the scenes that are so important, and instead of rushing into quick decisions? Could I come to you first of all, Maureen? You've already just talked a bit about you've got to negotiate things with your unions. You have to negotiate them with your governments too, I imagine.
Yes, definitely. Yes. But in relation to data, I think it was accepted by one and all that it was one of our greatest weaknesses. So basically, having access to data, having access to timely data, and having access to correct data is important for us to be able to plan. So we are tackling the issue of data from a number of fronts. So basically, it's having the live data of our current employees across the ministry, having the data from our educational institutions of our future supply of health professionals, having data from our professional councils related to all our professionals who are registered with the councils and who are actually working, whether they are working locally or abroad. So this is data which we required even during the COVID period and were not able to access. So it has become a priority basically for us, and I believe that everyone is on board. So whether it's the government or unions, or everyone is on board, because it would give us the opportunity to have a clearer picture of what we are going into in the future, basically.
Thank you. Justin, could I bring you in on this as somebody who's in the private sector rather than working with government, but not working under government, as it were, within this aspect? How do you see that, and how difficult is it to be sharing data, some of the data that's needed, and participating in the sort of national planning from somebody sitting in your position?
So the answer is it has been very difficult, and it is improving. So in terms of influencing government, it's not really our box. I think we really work with NHS England, and we work with regulators, and we don't have a lot of direct relationship with government. Sharing data, I think, is problematic in the UK, and I think it's probably problematic everywhere. First of all, there's such a plethora of bodies generating data. So even if you had perfect information exchange, you'd have to work out how you consolidate it.
Yeah.
The independent sector, I think, partly its own fault and partly a degree of not understanding, being quite separate. That's now massively improving, particularly patient safety data. But also when it comes to human resources planning, there is at the moment no shared planning, I don't think. And yet, we're enthusiastic to generate more apprentices. We could do so even better if we knew what the local workforce plans were. So I think the answer is data is key. It can be shared. You have to have a consistent data language, which everyone knows. And I think there's a lot of work, particularly in clinical data, to get that language consolidated. I, at least, am enthusiastic to end up with one shared information platform so you can have joint planning. But I would say it was early days at the moment in terms of that.
Yeah, no, very, very helpful comments. Beverly, would you like to make a comment on this one?
I think we've made great strides in our ability in England to understand the data we've got. And for so many of our workforces, the data is so fragmented. I want to get my hands on Justin's data, for example, because I want to know what allied health professionals he's got. But I also want to understand what his developmental requirements are for that workforce, so we can actually get to a far more intelligent space around workforce planning, which is not just the supply line coming in, but it's a developmental pathway onwards. And then how we build the capacity in the system to educate, train, supervise and support that workforce. So as far as I'm concerned, we have got to get better at understanding. If I look at my prosthetists and orthotists, there are not many in the country, but they are vital. We can't find that workforce because 98% of them are employed in private sector providers under an NHS commission. They're all doing NHS work, but they're not on our books. We cannot get hold of them. So there's a lot of work in NHS England ongoing to reach out, but we're also having to do workforce surveys, working with our regulators, etc., to be able to work through the detail of the workforce we've got. And where we do have great systems, as Maureen talks about, if you're looking at operating department practitioners, for example, many of them are not identified as ODPs on the workforce data. They are lost to us. So they come out as other or as nursing or as other theatre practitioner workforce, where we cannot separate them to be able to do the calculations around genuine demand and need in the different workforce groups. So there's real complexity, Nigel, I think, that we still have to work through to make sure we find this workforce wherever they work. Otherwise, we're making supply and demand assumptions on the basis of half the issue.
Yeah, great. You went to, while you were talking, you went to have seen the chat, Beverly, but there's Justin is saying that he wants to talk with Ruth and indeed Maureen about taking some of this discussion further. Justin, do you want to make a quick comment on that? I mean, that sounds like a very positive step forward.
Yeah, and of course Beverly as well. Yeah, very happy to share this. I think we've got 15,000 colleagues plus 8,000 consultants who work with us. So very happy to start engaging with everybody on how that workforce planning looks. There are some conversations starting. Happy to do more. Just responding to Ruth and Beverly and Maureen in particular.
Yeah.
But Nigel, let me just pick up on that. There's so many other opportunities for collaboration. The apprenticeship agenda, I'm so excited that colleagues are thinking about that because it's been transformational for us in looking at widening participation. I love Justin's example of our nurse colleagues who started in other industries coming through with an opportunity they would not otherwise have had. Again, with brilliant place-based workforce planning, we can really start to work collegiately and rotate and work far more synergistically, I think, across our sectors and across our systems, breeding a workforce that genuinely is able to meet the complexity of modern day patient needs.
Thank you. We better move on from the UK. This is an international discussion, but a good bit of collaboration going on there. Francis, this is obviously an issue for you. I know it's an issue for you. You and I have talked about it before, but you've also got private sector, by which you often mean charitable sector, of course, in a large part of Africa, don't you? And so this must be an even, even bigger issue in some ways. How are you trying to handle that? And then I'll come back, if I may, to Laetitia to make a comment on this as the researcher amongst us.
Okay, Nigel, just allow me to give you a piece of information on the health workforce working together. We now have what we call interprofessional training which we developed as part of the Medical Education Partnership Initiative, we recommend, and we do medical schools here in many African countries. When nurses, doctors, pharmacists, and physios come into the university, they all go into the same room to study physiology, anatomy, and so on. And those, as much as they can share together is so that they know a bit about what each other does better. So I just didn't mention that the other time. Let's come back to this one on data now. Health workforce planning is probably what you can call the name of our game. Do we know the skills that each a country needs to address the health needs of the people? And it will vary from country to country because the delivery system will vary. And the WHO now has what they call health labor market analysis tools, and they are training countries here in Africa on how to use that tool so that each country first will have a structure, an intersectoral structure in the country, which leads the health workforce planning, and they are assisted to get the figures, the numbers, through the technical work of people who are able to identify the health needs, the disease burden, and link them to the skill needs. And then that will go into the budgets and so on and so on and so on. But to convince governments to do this has not been easy. Just to form that intersectoral committee, we've struggled here in Uganda over the years. The Ministry of Education are responsible for training, but Ministry of Health employees. But the two have a history of not working together on this. That needs then some professionals, technical people, CSOs, non-government agencies, which could be able to do this, academia, and try and sell this to the authorities as much as is possible. And it is work in progress. We need advocates, the professional associations, and so on. But that's the way forward. Without health workforce planning, we are in trouble.
Thank you, Francis. Let me just give Laetitia a last word on this issue of data. And then looking at the time, I'm going to ask you all just to give me a one-sentence final comment before I need to make a couple of final comments at the end. So Laetitia, and I'll go around Maureen, Beverly, Justin, Francis, Laetitia. But Laetitia, have a first quick word on the data bit.
Okay, great. So just on the lighter note, Nigel, I wasn't sure whether it's a compliment when you said I'm the only researcher, but just for your info, I was head of the Gauteng Provincial Department of Health for 5 years. And so I kind of have insider knowledge, you know, as well of the difficulties of implementation. So Nigel, I think that the critical issue about data is actually to have a strong, capacitated technical unit on the human resources for health at the national level, in the case of South Africa. So I think that the proof of the pudding in terms of investment in the health workforce would be, for me, a kind of like a funded and capacitated technical unit, because that unit is able to use various policy levers to drive a change. In the case of, so Francis was talking about the tool of WHO, but ultimately you need in-country capacity that's sustainable to be able to use that, you know, that tool. I still think that our professional councils are probably the best source of data. And this is where I think that government can pass regulations that would oblige the professional councils to collect very basic information. I, for example, 3 questions that I think every year when a health professional has to register, which is a requirement for practice, 3 questions that could be asked. The first one is, are you practicing, and we can define what we mean by a clinician, yes or no. Secondly, are you in the country? yes or no? And thirdly, are you in an urban area or a rural area, yes or no? And that'll give us a wealth of information, which will enable us to do the planning. Thank you.
Thank you very much. Now, can I just ask for the one sentence final comment from each of you? Go to Malta first, Maureen.
I have an appeal, basically. I would like to appeal for us all to continue this connection and this collaboration in order for us to be able to plan a better future for our healthcare.
Brilliant. Thank you. Thank you. Beverly.
So my appeal is that I really do want us to fully utilise the full capability of our workforce. And then I echo Maureen's plea that we have got to collaborate together so that we do enable ourselves to support the stewarding of the professions across the globe in a way that does relate to each other, in a way that doesn't move some ahead of others. Nigel.
Thank you so much. Justin.
So I'll respond with a thought, just looking at what Naomi's been saying, which is, I do wonder if those nations which have got good training capability could have visibility of the training and development needs of the countries from which migration is happening, and have mutual training partnerships so that when their time overseas is over, they go back with the skill set that the countries they came from needed. So this visibility of global workforce needs strikes me as a very useful theme to have come out of this conversation and worthy of further exploration.
Thank you very much indeed, Justin. Francis, one sentence.
My one sentence. Can we re-energize the global health workforce movement? That is the answer to all these issues.
Yeah, I think you're right. I don't think there's anything centrally at the moment, is there, globally, that's really doing this. So that's a big question for us. And then Laetitia, a last one sentence for you before I have two sentences.
Investment in the health workforce is investment in data and in implementation.
Thank you very much indeed. So my first job at the end is just to say thank you to everyone. I mean, I think that's been really tremendous input from our speakers, and can I thank all the audience for their contributions as well. I just note why I'm going to pick up on Jed Byrne, who's made a couple of interventions late on in the chat session of pointing out that actually we've got to keep up this discussion because somebody's got the answer somewhere to the problem we're grappling with today. So how do we connect across that? And also saying that Health Education England, for which he is the head of the global head of Health Education England, forgive me, Jed, I've forgotten your title, but that Health Education England is committed to keeping this sort of dialogue going, which I think is terrific. So thank you to the speakers, thank you to the audience, thank you to the participants of all sorts, as it were. Thank you to the organisers for setting this up. I'm going to leave with one tiny little advert for the future, which is that in this whole discussion of the health workforce, we need to understand what healthcare and promotion and creation of health is going to look like in 15, 20 years' time. We need to know what we're looking at, and it's not just healthcare, it's about health much more widely. I co-chair something in the UK called the All-Party Parliamentary Group on Global Health, and we've recently produced a study on looking forward 15 to 20 years' time. What is the health workforce going to be doing in 15 or 20 years' time? And if you look back 15 or 20 years, you know it's going to be a big change. And you can think about technology and all kinds of stuff. We've headed it probable futures, which is the sort of consensus slate, and radical possibilities, which is where the people on the radical edge are actually thinking about what needs doing. And I will make sure that it's added to the chat before the chat is available fully to people, the link to it. But do look it up, because I think that bit of the debate needs to link with this bit of the debate, because who are we training and who are we planning the workforce for? And there are some very radical ideas coming forward around the world about how the workforce needs to change in the face of massive global pressures and in the face of massive national pressures. And I think every health workforce in the world today is under enormous pressure. and perhaps we should end by just paying tribute to them. So thank you all very much indeed for your time and for your inputs, and I think it has got some really interesting things following on from this, and I hope to hear in due course that some of the momentum generated today has continued. So thank you everybody for that very much. Thank you.